All right. Well, thanks for having me. I was able to mentor some of the students that helped start this program. So when I had the invitation, I was excited to take advantage of it. We are just finishing our residency application, and the timing was not ideal. I normally probably would have passed, but I'm very appreciative of the efforts that have gone into this program, and I think it's a very, excellent way to introduce students to neurosurgery. So kind of made things work. Got the application finished on late Sunday, and been working on this since then. So excited to be here. Thanks for having me. And we've been in New Mexico about 18 months, and my boss, Dr. Schmitz, our chairman, and another colleague and partner of mine, Dr. Cole, and myself, all came from New York to kind of rebuild the neurosurgery residency here. And vestibular schwannomas are, one of my favorite topics. They're fairly complicated, but as a brain tumor and skull-based surgeon, whenever someone comes to you with a tumor or a lesion in their brain, they, are nervous, they're anxious, particularly so the larger it is and the more symptomatic they are. And they always, want to know what's the plan, what's next. And a lot of times, there's different ways to remove tumors, and sometimes you can do them, minimally invasively. Sometimes you can do them, in this case, maximally invasively, where we take did an orbital dough, the orbital rims off bilaterally to get down along the base and remove the tumor. And really, what really matters at the end of the day is how the patients do. And in one person's hands, one treatment might get better results than another person. So it's always good to be learning and trying to find the best ways. But at the end of the day, what really matters is that your patients do well and that you have safe, ways to treat them the best that you can and get the best outcomes that you can. So when it comes to, anytime there's a lesion in the brain, I go through the same sequence with all my patients. What are the options when someone has a lesion in their brain? Well, one option is you do nothing. There's no need to follow up, no need to do anything more. This happens surprisingly, frequently. People have tiny little, spots or areas of calcification. Maybe an osteoma that on the bone edge that somebody thought was a meningioma, and so that's an option that happens. Another option, which is quite common, is to follow a lesion with continued imaging. There's different names for this: active monitoring, serial observation. What's often used in the acoustic literature, the vestibular schwannoma literature, is wait and scan, or my least favorite term, benign neglect. I never use that one, but it's in there. The third option is to biopsy a lesion and then possibly have treatment after that, depending on what it shows. We do biopsy lesions, but we generally won't do that if we can remove them, because it's a fair amount of work to get down to a lesion and to get tissue from it. So there are times where we do that, but the other common option, obviously, and this is neurosurgery, is to remove the lesion. And then there's an option for, radiating it, or some combination of removing and radiating. And if there's residual or if there's recurrent disease, you might repeat those steps when you see that as well. So I always tell my meningioma patients that I'm going to follow I'm going to follow their, even after surgery, and if we remove it all, that I'm going to follow them until one of us dies. And the older patients laugh, but even if that interval gets spread out, we want to continue to follow patients and make sure they don't have late recurrences. So when patients come to you with any sort of lesion in the brain, these are all the things you have to think about with them and go through with them in order to get them the safest, best resection possible. And when it comes to outcomes and how we measure what happens with surgery, how the surgery went and how the patient did, there's obviously always going to be extent of resection. Did you get all the tumor out? Did you leave some? If so, how much? What's the plan? And then really what people want to know outside of did you get it all, doctor, is how's the patient going to do? Is there a deficit? A lot of times there was a deficit in the beginning. Is it worse? Is it better? Is it short term? Is it long term? And then there's also, such as in tonight's topic with vestibular schwannomas, there's tumor-specific outcomes. For example, if you have a patient that has a large pituitary macroadenoma, in addition to the normal outcome measures of extent of resection, You also look at, in this particular case with pituitaries, oftentimes visual compromise was the reason the surgery was, recommended. And so you'll also look at visual outcomes. You'll look at endocrine functions. Do they have hyponatremia postoperatively? Do they have diabetes insipidus and need either temporary, as is most common, or occasionally permanent hormone replacement, DTVP? And then obviously there's certain complications based on the types of surgery. So CSF leak is one that can, happen with pituitary surgery. So each disease has their own specific profile for these things. You have to weigh all these factors when making these decisions. If someone has questions, feel free to put them in on the chat. We can stop at any time. This is a patient that we treated a few months ago that had a very large, giant, even cystic vestibular schwannoma. And what are the goals of treatment? A lot of the things we'll talk about tonight as we go through these, some of them, speak for themselves. If you have a giant acoustic, very few people are going to counsel someone to just follow that image or to do nothing. They generally come in pretty symptomatic from that. And so, it really depends on the individual patient and the, specific circumstances that lead up to that. So with vestibular schwannomas, we obviously do look at, extent of resection. And in this particular case with vestibular schwannomas, acoustic neuromas, we look at, deficits in particular with respect to facial nerve preservation rates and also hearing outcomes if their hearing is salvageable, serviceable. Other tumor-specific outcomes we look at with acoustic neuromas and vestibular schwannomas is dizziness or balance, headaches, CSF leak rates as well. And I'm going to use, since we moved to New Mexico, I'm going to just transition slides. There's a lot of amazing Native American cultures in New Mexico, and my family and for generations has been in the West. And this is a Ute first phase Navajo Chief's blanket, which the one on the left is in the Metropolitan Museum there in New York, and the one on the right is in the De Jong Museum in San Francisco. But these were kind of one of the hallmark weavings of the Native American cultures and was kind of the gold standard of kind of the top item in the Southwest and into the Plains tribes for the amazing craftsmanship behind it. So this will be transition point. So this is some background for vestibular schwannomas. 8% of all tumors, but the number one CP angle tumor, and the vast majority is sporadic. Occasionally you'll get familial or NF2 where you get bilateral. And I think your Greenberg will say that there's a triad of over 90% that have, these three symptoms, but there, a lot of these background data I'm using are from Dr. Carlson, Dr. Link's article in the New England Journal of Medicine reviews it, and ipsilateral sensorineural hearing loss is greater than 90%, dizziness and balance greater than 61%, and asymmetric tinnitus at 51%. So interestingly, tumor size has a limited association with severity of tinnitus, hearing loss, and dizziness. And also symptom progression is not strongly associated with tumor growth. So we do have to follow these tumors serially and closely because worsening audiovestibular symptoms are not reliable measures of tumor growth. And also an important point is sensorineural hearing loss and vestibular hypofunction are not reversed with tumor treatment. They don't get better or rapidly improve. Another reason we have to watch vestibular schwannomas closely is they can be unpredictable in their behavior. And there's limited high-level evidence, as we'll kind of focus on tonight, what evidence is out there. And then there's also multiple quality of life factors. And this all leads to significant variation in management within the US and in the world. And frankly, that's why I think they're my favorite tumor and to talk about with respect to, what's the best thing to do and to research, because it's not clear-cut which way to treat these all the time, as opposed to that first giant meningioma I showed, or where the patient needs surgery to try and improve. With vestibular schwannomas, there's a lot of art that goes into it. There's a lot of discussion with your patients, and there's a lot of pros and cons to different treatments. And I think it really is kind of the pinnacle or the challenge of all the neuro-oncology and school-based cases of what to do. And you have to know your patients, you have to know yourself and your center, and try and figure out what the best thing is to do for the patient. It's particularly important because there's been a significant increase in incidental tumor detection in the era of MRIs, and it's especially true for older patients. And in all of skull-base and neuro-oncology, but in particular with acoustics as well, there's been a shift to a more conservative philosophy that focuses on preserving neurological function as the top priority, as opposed to just removing the tumor no matter what. And I think that's important. And we'll talk about that. This is a nice figure from the Carlson and Link New England Journal article that shows that overall it has, in the pre-MRI era, you had this group of patients and the majority were treated. In green, a very small number were observed. Nowadays, if you look at on the right, the current, you have a lot more patients detected, and there's a higher percentage of patients that are observed, but there's still way more patients treated than there were in the past. And so that brings up the question of, well, are we over-treating and taking the cost of treatment and the complications, treatment associated with that? But over the last 40 years, with the increased MRI, we've found many more vestibular schwannomas, and the diagnostic age went from age 49 to 60, so patients are getting older. The tumor size went from 2.8 to 0.7 centimeters, and patients had better hearing. That's from a Scandinavian cohort over 40 years, but it reflects kind of general trends. So we're finding these tumors in older patients. We're finding them smaller and with better hearing, and that changes the decision-making process and the factors that go into it. This is just showing that reference, that article that came out in April, which is fantastic. A lot of this background data is based on it, and everyone should read it. It's not super long, but it's very, very good. These are some figures from that same talk. Show the anatomy and the vestibular schwannoma pushing in on the brainstem and the pertinent neurovascular anatomy around it. So as we talked about, you have a lesion in the brain, and especially specifically with vestibular schwannomas. What are your options? Do nothing. Never really an option with vestibular schwannomas. We at least want to be aware of them and follow them. And then what interval do you do wait and scan? There's not a huge role for biopsying vestibular schwannomas, but there are a lot of decisions to be made about these other steps. So when it comes to the choices of watching and scanning, so following closely or radiating or resecting the lesion, and then if you are going to resect the lesion, which approach do you use? Do you do a middle fossa if it's small? Do you do translabyrinthine approach or a retrosigmoid approach? And from the good news is for most patients, there are reasonable treatment options that provide a low morbidity and a minuscule mortality rate. But each management technique and strategy has different advantages and disadvantages. And so when evaluating patients with this, you have to weigh all these factors, and it helps to know the literature. This is just showing from that same article, it's showing the radiation, stereotactic radiosurgery, and we do that for tumors that are generally less than 3 centimeters is quoted, but generally less than 2.5 centimeters to get that fall off, that nice fall off without having surrounding damage to the very important area in the brain. And there's different ways of doing that, whether you're using a Linac system in C or a gamma knife system. There are different techniques and ways to deliver that radiation. But radiation treatment is successful in halting the tumor growth in more than 90% of cases. And it usually doesn't disappear, but it may shrink and ideally halts the growth. So these are looking at the 3 different approaches: the translabyrinthine approach, retrosigmoid, and middle cranial fossa. And each has kind of their own advantages, disadvantages. With the translabyrinthine approach, patients lose hearing, and you need a fat graft to avoid CSF leak, but you get a nice view of the IC and the fundus. You can identify 7, the facial nerve, really early, and you get a nice view of the lateral view of the brainstem. Retrosigmoid is kind of a workhorse approach for neurosurgeons. You get a great view of the posterior fossa. You can attempt hearing preservation with small tumors, but it can be difficult to visualize laterally, aspect of in the IAC, and sometimes you need you need to have some cerebellar retraction, or it can be difficult to at least to look towards the brainstem side with a large tumor and a full brain. And then the middle fossa is generally preserved for small tumors with, that don't go into the IC too much. And the advantages are you get it gives you access to the full length of the IC, and you can attempt to, do a hearing preservation surgery. The downsides are that you have a, limited CP angle access for larger tumors, and that you can need to do some temporal lobe retraction. So those are kind of some of the background on the surgical approaches. And, with vestibular schwannomas, the size of the tumor is really oftentimes what drives recommendations, but there are patient and provider related factors which do exist and influence your treatment. And so, if someone has a giant meningioma or, even a giant metastasis or other type of tumor, a lot of times we, need to remove that tumor because of the symptoms patients are having, and it's, pretty clear they need surgery. The interesting thing, and what I think makes vestibular schwannomas fascinating and to study and to treat these patients these are benign diseases, and they're diseases where, you have patients that have larger tumors that don't want anything done. You have patients with smaller tumors that want them removed. And there's a whole spectrum that depends a lot on patients and, what matters to them and so forth. And so, as skull base and neurosurgeons and medical doctors in general, always try to remember to do no harm, the primum non nocere, part of the Hippocratic Oath. And, part of that is, what I call the showdown from the old TV show, The Price is Right, where, you don't want to, you would always lose in that. They try and guess what the cost was of this showcase item. And, you just couldn't go over. And so when we're talking about vestibular schwannoma surgery, some would advocate for, going for a gross total resection, for the vast majority of times, but you never want to damage the facial nerve completely and, cause permanent facial nerve paralysis. And so I think there is a, very vital role for subtotal resections and radiation at times as well. And I'd rather, do that and more times in certain situations than causing a permanent facial nerve paralysis in somebody. And, so you want to always remember to, do no harm is first and foremost. Just this transition slide, this is the four corners. You got Utah in the upper left, Colorado in the upper right, New Mexico, where we're from down here in the lower right, and then Arizona on the left. And this is showing a bunch of different, what were called trading posts, and really where the different Native American populations, the Navajo and Hopi in this area, and these different trading posts really influenced the development of this Navajo weavings. This is my daughter in one with what's called a Kalagato weaving from 1920, and that trading post there on the right in the orange circle, the Ganado and Kalagato trading posts were in that area, and each trading post had kind of their own techniques and styles that developed largely times based on what East Coast buyers, this is back in around the turn of the century, 1900, what they were interested in, and really influenced the development of these different patterns based on what people were interested in getting. So today we're going to go over a bunch of different looks at evidence and classification of evidence. And so for this first section, class 1, 2, and 3 evidence. So class 1 is well-designed randomized controlled trials. And then, it gets lower in evidence as you go down. Class 3 is just expert opinion, case series, case reports, and studies with historical controls. And then the level of recommendation at the bottom, level 1 is generally accepted principles for patient management, reflect a high degree of clinical certainty. And then as you get down to level 3, which is, other strategies for patient management for which the clinical utility is uncertain, inconclusive, or conflicting evidence or opinion. So the strength of the evidence and the strength of the recommendation is up at level 1. So this is from the New England Journal supplement, but it goes through, the major consensus guidelines and position papers on sporadic vestibular schwannoma management over the last 5 years. So as you look at, most of these came out in 2018, and this was in a special edition of Neurosurgery where they answered some of the most important questions with vestibular schwannoma management. So this seems like a good place to start. And as you go through all these are all important questions. So, there's an executive summary, and then it looks at, guidelines for the treatment of adults with vestibular schwannomas, looks at the methods, and then asks specific questions. And we'll go through those. looking at hearing preservation, cranial nerve monitoring, diagnosis and management, and then evidence-based guidelines on, prognostic factors and role of radiation, and on surgical resection and different treatment, options. And then there's some that are more based on, what's the interval of MRI, how do you define growth, and, what are the indications for performing a screening MRI? We won't look at those because they're not really involved in the management as much. And then there's a position paper looking at stereotactic radiosurgery, and then looking at this a modified Delphi study looking at a consensus on sporadic vestibular schwannoma care, and then looking at these guidelines, both of these papers in the last couple of years on surgical management for large vestibular schwannomas, a systematic review, meta-analysis, and consensus statement. So this is the big paper that came out in 2018. And I was really excited at the time to see this come out, to see what the CNS and these are all some of the the leaders in the field had put together, to look at, make some high-level guidelines and recommendations for patients with vestibular schwannomas. And almost 3,000 papers were reviewed, and they went through this data. The papers had to be patients over 18, vestibular schwannoma papers, human, obviously, and then published between January of 90 and December 31st of 2014. Quantitative results, and had to be in vivo, not biomechanical, not cadaver, had to be in English, wasn't an abstract or editorial letter, etc. And you had to be able to isolate the vestibular schwannoma data from the paper if it was multiple pathologies, and they had to be, couldn't be small series. They did not include systematic reviews, guidelines, or meta-analyses conducted by others, as they did their own. And so there's 11 questions we'll look at, and you'll see a common theme kind of quickly emerge, because these are all great questions that are asked. Number one, what surgical approach for vestibular schwannomas are best for complete resection and facial nerve preservation when serviceable hearing is present? And you'll see on a lot of these recommendations that, the answer doesn't quite give us a lot of guidance, because a lot of these answers there's insufficient evidence. So insufficient evidence to support the superiority of the middle fossa or the retrosigmoid approach for complete vestibular schwannoma resection when serviceable hearing is present. As we said earlier, if you do a translabyrinthine approach, then you take away hearing. But this was for patients who had sporadic vestibular schwannomas who underwent microsurgical resection, so either retrosig or middle fossa. Out of those original 3,000 articles, 218 articles were removed, and they got down to 205 at the end of it, and for full text review, but 17 were available for this, first review question. And then they summarized those, but essentially the discussion points were both these approaches can preserve hearing. And so there may be some characteristics such as small lateral-based vestibular schwannoma tumors in the IC may permit greater hearing preservation by middle fossa. Facial nerve preservation rates were higher with retrosig, and those with serviceable hearing undergoing resection or lesion. But the evidence from these studies was drawn from class 3, and there was no class 1 or class 2 evidence. And so, really at the end of the day, the recommendation is, the evidence was insufficient to give one, standing answer or writing answer for that. So question 2 is which surgical approach, translab, retrosig for vestibular schwannoma is best for a complete resection and facial nerve preservation when serviceable hearing is not present. As a lot of times patients that have non-serviceable hearing, people use that as a reason to do a translabyrinthine approach, for example. And once again, the recommendation was there's insufficient evidence to support the superiority of one technique over the other. And got all the papers were whittled down in this case to 22 that remained to discuss in this, and the discussion points were both translab and retrosig permitted facial nerve function preservation in patients that did not have serviceable hearing, but for which a gross total resection was attempted. The evidence for this guideline was drawn from studies with class 3 evidence. So once again, no class 1 or 2 evidence exists to guide recommendations. And so, that's an important point when looking at these. Question 3, does vestibular schwannoma size matter for facial and vestibular cochlear nerve preservation with surgical resection? Well, there at least was enough recommendation in this case to make a recommendation of level 3. patients with larger vestibular schwannoma size should be counseled about the greater than average risk of loss of serviceable hearing. So the larger the tumor, generally the worse outcomes across the board for vestibular schwannomas. And that's something you can kind of write down. And there's one point to take away with vestibular schwannomas as a medical student, the larger they are, the worse the outcomes tend to be across the board. And that's true for facial nerve outcome. It's true for, when hearing preservation is attempted as well. And so this goes through the study selection. And there's 44 articles that went into this to answer this question. And class 3 evidence supports the conclusion that tumor size is a strong predictor of hearing preservation and facial nerve preservation after microsurgery resection. Once again, though, just class 3 evidence. But still, I think it's also logical and makes sense. And so, even though it's, based on expert opinion, case series, case reports, studies with historical controls, it's logical and I think is sound and makes sense. Next question, should small intracanalicular tumors be surgically resected? Well, this is an important one because there's lots of patients that present to you with small tumors that are 1.5 centimeters or less. And unfortunately, recommendation, insufficient data to support a firm recommendation that surgery be the primary treatment for this subclass of vestibular schwannomas. And total of 36 articles were used on this. Only 13 included in the final analysis. Usually the other 20 were excluded because they did not have tumors confined solely to the IAC. So when looking at these discussion points, there's excellent rates of resection with tumors that are smaller than 1.5 centimeters. There's excellent preservation rates of facial nerve and excellent hearing preservation rates for these IAC vestibular schwannomas, but there's insufficient data to support a firm recommendation. That surgery should be the primary treatment for this subclass of vestibular schwannomas, as there hasn't been, a head-to-head for these types. These are also the types of tumors at less than 1.5 centimeters that you can follow. That if you do radiate them, that they'll have extremely high control rates. So there's still insufficient data to know what the best thing to do for these patients is necessarily. Question 5, is hearing preservation possible when surgical resection with vestibular schwannoma surgical resection when serviceable hearing is present? And then the level 3 evidence, hearing preservation surgery via the middle fossa or the retrosigmoid approach may be attempted in patients with a small tumor size and good preoperative hearing. And so, this makes sense. It's down to 27 articles for that analysis, and it suggests that hearing preservation surgery using either a middle fossa or retrosig for removal of a small to medium vestibular schwannoma in patients who have good hearing, that is a reasonable goal. But one problem as you go through the literature with vestibular schwannomas is defining hearing, how people define hearing pre and post-operatively and which system is used. And there's been a lot of, different, audiologic classification schemes used over the years. And a lot of studies don't have them pre and post-operatively. And then there's multiple different schemes that can be used. And so without one universal, hearing acceptance, it's been difficult in the literature in the past, but at least, this is a good thing to try and do, attempt hearing preservation surgery with a small tumor in someone that has good hearing. But once again, I think that's pretty logical. It's good to see that there's a level 3 recommendation, but I think that's what, patients with small tumors and good hearing that end up having surgery, that would clearly be the goal for those patients. Level 3 again. Question 6 talks about NF2 patients, which is not really the scope of this talk tonight, but once again, a common theme, there's insufficient evidence for, that surgical resection should be the initial treatment for these patients. So we'll kind of skip this group. And then question 7, does a multidisciplinary team consisting of neurosurgery and neurotology provide the best outcome of complete resection and facial vestibular cochlear nerve preservation for patients undergoing resection of vestibular schwannomas? I think there's very few centers that only use, a neurosurgeon or a neurotologist for these. Everywhere I've ever been and seen or heard of, it's done as a team. And we are part of the North American Skull-Base Society distinction site that believes in a multidisciplinary center. And I think that's how, the vast majority of places are. But looking at, the 4 articles they include in their final analysis, there was insufficient evidence for them to recommend that vestibular schwannomas be resected with a neurosurgeon and a neurologist. But most of the high volume school-based centers use both, as we said. Question 8, does a subtotal surgical resection of a vestibular schwannoma followed by SRS to the residual tumor provide comparable hearing and facial nerve preservation to patients who undergo a complete surgical resection? And there's insufficient evidence. This was looking at 13 articles at the end, and the discussion point: when a vestibular schwannoma is treated with subtotal resection followed by radiosurgery, tumor control rates are consistently 93 to 96%, with over 90% of patients maintaining normal and near normal facial function, and that's similar to series of gross total resection. But the facial nerve preservation is consistently better than the wide range of facial function preservation reported for gross total resection. So this is a common strategy that I think is a good strategy for a lot of patients, and doesn't have sufficient evidence for a recommendation from the committee, but is a strategy that's commonly employed. And question 9: does surgical resection does surgical resection of vestibular schwannomas treat preoperative balance problems more effectively than SRS? This is something I commonly heard at times in training, and that we tend to believe as surgeons is that if patients have preoperative balance problems, they'll do better with surgery versus radiation or observation. And I think that tends to be because we believe in intervening when there's a physical presence of a lesion. But when you look at the literature, they got it down to 16 studies. 10 looked at balance improvement after treatment with gamma knife or surgery, and 6 compared the two side by side. And 6 studies used questionnaires, which the Dizziness Handicap Index, which is a great one, was the most common. So this says the discussion point: vestibular symptoms seem to worsen in a minority of patients treated with both methods. Basically says, future study is recommended, as there's little data to support using SRS or microsurgery when the goal is primarily to improve balance. And the data that exists is not clean. It's full of selection biases, and particularly when it comes to tumor size. In general, smaller tumors are treated with SRS and larger tumors are surgically resected. So then obviously tumor size in that case can be confounding. And the relationship's kind of difficult to tease out, essentially. So last couple of questions here. Does surgical resection for vestibular schwannomas treat preoperative trigeminal neuralgia more effectively than SRS? Level 3 surgical resection, may be used to better relieve symptoms of trigeminal neuralgia. This one's the most obvious, I think, to me. If you have a large tumor that's pushing on the trigeminal nerve, people have trigeminal neuralgia from that. Physically removing that compression of the nerve is going to help people feel better, typically. But based on the quality of the literature that's out there, finally looking at very few studies when it was all said and done, they were unable to make a sufficient recommendation higher than level 3. But I think this is common sense and is something that most neurosurgeons and neurologists believe. Final question: is surgical resection of vestibular schwannomas more difficult after initial treatment with SRS? And that did meet level 3 criteria. If someone has to have surgery after they've been radiated, it's recommended that patients be counseled. There's an increased likelihood of subtotal resection and decreased facial nerve function, which does give you pause when counseling young patients who maybe want to have radiation and not amenable to surgery for whatever reason. You do have to counsel them that there is an increased likelihood of a subtotal resection and a worse facial nerve outcome if they have surgery down the road, as a general rule. 22 full articles were looked at for that topic, 12 excluded. And so, it's still a pretty small group of evidence, but class 3 evidence supported subtotal resection in patients with previous radiation to preserve facial nerve function. And there's no level 1 or level 2 studies, but we do tend to feel that when you have been radiated, it's more difficult. So in those patients, it's often advocated for a subtotal resection, going back to that Price is Right showdown principle of not wanting to overly be aggressive and treat and cause a facial nerve paralysis. So let's take a step back. Sorry, that was a lot to go through, but when I first saw this came out, I was like, here's all the answers for vestibular schwannomas. We're gonna have all the guidance going forward. But really the four points that there was evidence for, and it was all level 3, were that patients with large tumors should be counseled about the fact that they have a greater than average risk of losing serviceable hearing if they have surgery with hearing preservation. Well, that's common sense. Hearing preservation surgery may be attempted in patients with small tumors and good hearing. And so it's not even like should be, it's like those are the ones you can try and, save their hearing for. And then surgical resection of vestibular schwannomas may be used to better relieve symptoms of trigeminal neuralgia, when compared to radiation. Well, I think a lot of us already, knew that, like I said, common sense wise, of when you have physical, compression of something, typically removing it versus, just radiating it and getting, arresting the further growth, it's going to relieve the symptoms of compression better. We see that all across different pathologies within neurosurgery. And finally, surgical resection after radiation likely has an increased risk of decreased facial nerve function, and increased chances of total resection. I think we knew all that. So, this did a good job of defining all the evidence and the guidelines, but did not, I think, solve a lot of the questions that we had about vestibular schwannomas. This is a kind of getting back to the transition point here with these Navajo weavings. This was a famous episode on the show, Antique Roadshow, where this super nice, farmer had this weaving hanging on his couch ever since his whole life. And they were not a particularly wealthy family, but his grandmother had received it from the famous mountain man, Kit Carson. And it ended up, he had no idea, but it was, worth over $500,000. And another viewer had seen that and had this blanket that was kind of the only thing he had inherited from his mother after his siblings had picked everything out. And he was on disability and was extremely poor. And he saw that first episode of this Antique Roadshow and pulled this blanket out and took it to an auction house and ended up selling for $1.5 million. And the person that bought that sold it to a couple who bought it for $1.8 million and donated it to Metropolitan Museum of Art. So a pretty amazing piece of American history. This is jumping to the other articles. This is a consensus statement and meta-analysis for stereotactic radiosurgery for vestibular schwannomas from the International Stereotactic Radiosurgery Society. It's the practice guideline published in 2017. And they looked at the literature, total of 55 full text articles, and their conclusions. There's no randomized trials to help guide management of patients with vestibular schwannomas. So they make some consensus statements. They're using a little different level of evidence as seen on the right. Level 1A is systematic reviews, all the way down to level 5, which is expert opinion. So this is kind of interesting when they're looking at, their first level 5 recommendation is that you can diagnose acoustic neuroma just based on the MRI, and strong consensus. Well, I think, that's pretty common knowledge, not super exciting there. So, for small newly diagnosed vestibular schwannomas that don't have mass effect on the brainstem, is observation an option? Strong consensus reached with 80% of the members saying agreed or, strongly agreed. Evidence is still case series level, so still somewhat poor. Surgery for patients with a new small diagnosed vestibular schwannoma. Consensus not reached, only 10% strongly agreed, strongly disagreed 20%, agreed 40%, disagreed 30%. So really kind of all over the board on that, which I think makes sense if you're just asking for surgery in general for small newly diagnosed vestibular schwannoma without significant mass effect. Because how old is the patient? How healthy are they? There's a whole bunch of other factors that go into this, which is going to be kind of takeaway theme from this as we look at all this literature. So for single fraction radiosurgery, I thought this is probably the funniest part of this talk. So someone that when they ask about, this is the Stereotactic Radiosurgery Society. So if you ask if single fraction stereotactic radiosurgery is an option for these patients, 100% strong agreement. So just thought that was interesting for a tumor that is newly diagnosed, is small, no mass effect. We don't know if it's growing, not growing, how old the patient is, but 100% strong agreement that that's single fraction radiosurgery is an option. So I just thought it was interesting. And only 60%, agreed that fractionating the radiation was an option. So for growing vestibular schwannomas, so for 3A, surgery is recommended for vestibular schwannoma in surgically fit patients with significant mass effect. So just to reiterate, because I think this is kind of a little interesting. So when someone has, sorry, I'm gonna go back one. When someone has a tumor that is management right there in the middle, management for small newly diagnosed vestibular schwannomas, no mass effect on the brainstem, but there's a small tumor that's diagnosed. When it comes to surgery, no consensus all over the board. But when it comes to radiation, 100% agree it should be radiated. But now you've got a tumor on 3 that actually has significant mass effect on the brainstem. So it's really compressing the brainstem. And when it's asking about the recommendation for this tumor that we know is growing in this case, is surgery recommended? And, strongly agree 40%, agree 60%. So there at least is a consensus of 100% that they should, that it should be treated. But it's just interesting to me that, it seemed like a little less strong than it was, even though it's a much larger tumor with significant compression of the brain. And then looking at 3B, surgery is recommended for small to moderate sized vestibular schwannomas without significant mass effect. No consensus. Half agreed they should treat it, but 30% disagreed, and then 20% strongly disagreed it should be treated in that case. But there was no mass effect, at least. But it is, it is growing in this column in this row for 3s for growing vestibular schwannomas. So, and I think that maybe because there's no significant mass effect. So then asking this question, single fraction radiosurgery is recommended for small to moderate size vestibular schwannomas without significant mass effect. And so, this does make sense. Strongly agree 70%, agree 30%. Nobody disagreed or strongly disagreed. So consensus there that if you don't have mass effect on the brainstem and you have a small tumor or to moderate sized tumor, that single fraction radiosurgery is a recommendation. I think that makes some sense. And then fractionating, people weren't as strongly in agreement with fractionating the radiation there. This is different. That first blanket we looked at last time, which did not have these extra stripes on it, it was called a first phase. This is a second phase. It gets a little more, fancy in terms of extra things added. And this is kind of what's called a third phase, which is one about the most common and desirable of the Navajo weavings, and are quite expensive. This one I think is $15,000, so quite pricey. Heading over to these last couple papers. This is just in the last couple of years, July of 20, last summer. Surgical management of large vestibular schwannomas, systematic review, meta-analysis, and consensus statement on behalf of the ENS skull-based section. And so we're looking at these really large tumors, and this is basically saying in the results that tumor classification grades should be used. So it's trying to standardize how we talk about the tumors, and large is defined as greater than 3 centimeters in the largest extrameatal diameter. So the part that's outside of, not the part within the temporal bone, but out in this, in the, CP angle. And then you should use the grading scales for pre and post-operative hearing. Gardner-Robinson or AAO HNS is what you should use for hearing, and facial nerve function using House-Brackman. Those are what you should be used for reporting functional outcomes. And there's a lack of consensus to support the superiority of any surgical strategy with respect to the extent of resection and use of adjuvant radiosurgery. So kind of repeating a similar theme, that there's not, one way to do things with this that has good evidence behind it. But the main goal of management of large vestibular schwannoma should focus on maintaining and improving quality of life, making every attempt at facial and cochlear nerve functional preservation while ensuring optimal oncological control, thereby allowing to meet the patient expectations. So doing the best you can to remove as much of the tumor you can without damaging the nerve, which is really not all that helpful, because that's kind of the game and the goal of all vestibular schwannoma surgery should be, which is to get as much of the tumor out without damaging the nerve, the facial nerve permanently, and preserving hearing when possible. So the evidence is still pretty low on this. So this kind of becomes a little bit more of, consensus. And a lot of this isn't, stuff we need to go over, like how to measure tumor size, the classification grades, but they do divide it up. If it's over 40 millimeters, it's giant. Over 30 is large. Just teaches, talks about recommendations which are not new, about using audiometry, different hearing, and then looking at quality of life. And once again, insufficient evidence to, support, to say that one surgical strategy is superior to others, or not just approaches, but the strategy of gross total versus sub or near total resections with or without radiosurgery. And then neuromonitoring should be used, which I would think is obvious whenever trying to preserve facial or cochlear nerve function. Up front, stereotactic radiosurgery is not recommended for large vestibular schwannomas with compression of the brainstem. Once again, an obvious one, I think, but still only level C. If you're going to do an approach of subtotal or near total surgery followed by stereotactic radiosurgery, then, they make a level C recommendation that, should give it 3 to 6 months after the surgery before doing radiation, just kind of get a baseline. And, they do say single fraction stereotactic radiosurgery can be performed with low marginal radiation doses of 11 to 14 gray, high local tumor control, minimal risk of facial palsy, and high hearing preservation rates in patients that have good pre-treatment hearing. So, when you look at all treatment modalities, when we're looking at the facial nerve, radiation does the best job, because you're not physically going in and manipulating the nerve like you are with surgery. And if patients have good pre-treatment hearing, and then especially the smaller the tumor is, you can have good hearing preservation rates as well, in addition to good local tumor control. Evaluating the health-related quality of life, including facial nerve function, represents a primary requirement in the management of patients with a vestibular schwannoma and should be assessed before and after treatment. Just saying we should be using quality of life, surveys and outcome measures for these patients. And then hearing preservation should form part of the preoperative discussion, and should be, one of the outcome measures looked at, and factors into quality of life and, whether you need to do postoperative hearing rehabilitation. And then interestingly, all patients should be counseled about non-negligible risk of persistence or new onset tinnitus after surgery, and also the limitations that exist with respect to proven treatments for this. So a lot of people, they have tinnitus and they'll want to do surgery to get rid of it, but we have to make them, make sure they know that may not go away all the way. And there's not a lot of great treatment options for it if it persists. Some of this just looks at your follow-up intervals. And then for subtotal resections, recommend an MRI at 3 or 4 months to ensure that, nothing's changed significantly, and look at your volume. And then, prescribes, scales for timetables for follow-up. This is another classic pattern called a storm pattern, Navajo weaving, which is fairly famous and was localized to a particular area of those trading posts. So kind of the last, as we get towards the end of this kind of section, one of the last most recent articles by this group of 16 experts is working toward consensus on sporadic vestibular schwannoma care, a modified Delphi study. And they looked at a bunch of different aspects of this, and then, used the four of the people that kind of led the study, then got these other 12, and so a total of 16, to look at these statements, and they basically revised these statements until they could all kind of come to some sort of consensus or agreement on it. And so the steering committee, as they call them, developed these items. Then the 16-member panel voted on them with these questions. Is the item of sufficient clinical value to warrant inclusion? Is the wording of the item clear and precise so it's not misinterpreted? And are there additional items that should be included? They then would do a conference call with the steering committee, reviewing everyone's responses and drafting, the agenda for this conference call. And then they'd go through the statements. They'd discuss different edits and revisions, and then they start doing voting, where they would try and get consensus. And a lot of times they'd have to, go back and modify the wording so that everyone kind of agreed to what it says. And they did that until they finally got, to voting round 3 all the way and to get consensus. And so I think going forward for the future, I thought this was beyond the scope all the way from the medical student standpoint of the lecture, but there are all of these, this tells you on this column what round this recommendation or consensus statement was accepted and with what percentage people agreed. If it's something that's not controversial or pretty adopted, you're going to see VR2, so accepted kind of right away, and then 100% agreement. So larger tumor size, this is number 7 looking at, increases the probability of progression to non-serviceable hearing following single fraction stereotactic radiosurgery for vestibular schwannoma. So that larger tumor size, causing, having a higher chance of going progression of non-serviceable hearing following single dose radiation. And they kind of divide this up by section. So this is all about hearing preservation with radiosurgery. And then as you go down, there's hearing preservation with microsurgery. This is PTA is pure tone average. Word recognition score is the next. And I didn't want to get bogged down in the hearing, details for this lecture tonight, but just different ways of measuring that hearing. Number 22, when considering the goal of hearing preservation and facial nerve outcome for an intracanalicular tumor, so one just in the bone, doesn't go out the CP angle, the choice of surgical approach should be primarily determined based upon surgical team experience rather than theoretical advantages and limitations of the middle fossa of the retrosigmoid. In other words, as a team, do what you're comfortable with and experience, not just what's, recommended by others for that type of case. A strong consensus. Another easy common sense one, VR2 and 100%. Larger tumor size associated with greater probability of losing serviceable hearing following microsurgical resection of vestibular schwannoma. And as I said earlier, that larger tumor size, associated with worse outcomes is pretty much goes across the board with vestibular schwannomas. Poorer baseline hearing is associated with greater probability of losing serviceable hearing following microsurgical resection of vestibular schwannomas. Once again, high consensus for that. Male or female does not impact the probability of losing serviceable hearing following surgery. High consensus. So gross total resection versus a near total and subtotal is associated with a greater probability of losing serviceable hearing following microsurgical resection. Once again, not very controversial. Maybe I'd say the one that had the lowest percentage agreeing with it and took the most rounds is older patient age does not independently impact progression to non-serviceable hearing during observation. So that's kind of one that wasn't adopted. And then solid versus cystic nature of the tumor does not impact progression to non-serviceable hearing. So anything in the 60s, whether there's a fundal cap out laterally of CSF, affecting hearing, those are the things that were a little more, controversial, but they revised them eventually till they could get them passed in round 3 for a couple of those. And goes into preferred treatments and presents, different scenarios, and trying to get consensus on this. And some of it looks at medications, aspirin, not enough evidence, bevacizumab, same thing. And formal vestibular rehabilitation should be initiated for patients with significant persistent vestibular complaints occurring after treatment or during the course of observation. It's another one that seems to be obvious to have strong consensus. Operative considerations, you should use monitoring if it's large. You don't need to get it frozen. It just goes into different things this way that, I think makes sense, and it's still nice to see kind of get put on paper and give some consensus to it. And the Navajo were kind of, taken over by the United States government. They're moved to a reservation kind of out of their native homelands, and they were provided with their own yarn instead of having to shear it off of sheep and clean it and hand card it. And so they went through this period where these are called Germantown weavings because it was from Germantown, Pennsylvania, and represents a significant transition point around 1870 in their weavings. You get a lot of these very complicated and kind of bright design. So the last couple of minutes, in our research, I've been interested in vestibular schwannomas since I was a resident, and we had a very healthy population in Utah where I trained. And so, there's people publishing papers on vestibular schwannomas where patients were older and sick, or patients were sicker, and they weren't as healthy as our population. And they were saying that, it was old age that was, the factor for why patients were doing worse. And, when we looked at it, we found out that our old patients didn't do any worse. And so this was kind of my first kind of interest in developing this idea of looking at, older patients. When we looked at, these outcomes, we didn't find any significant differences in age between the older and the younger patients. And that kind of led into, me studying frailty or looking at people's health status affecting outcomes, and figuring out that it wasn't probably the age that was the issue, because you had two groups of patients that one said, the age didn't matter, one said it did. So there had to be something else going on. And so we showed that older patients could do as well as younger patients. And so that shouldn't be a reason not to have surgery, particularly if you're healthy. And then when we looked at that same group at the University of Utah, looking at, frailty, we showed that it was really people's health status and their frailty that was determining, how long they were staying in the hospital versus, just age alone. And then that led to this, paper that one of the medical students in New York, Alice, and our team wrote that was published a couple months ago in JAMA ENT, JAMA Otolaryngology, and, that showed, as this rock curve shows here, that it was really, frailty is a more accurate predictor of outcomes for vestibular schwannoma patients for guiding treatment decisions than just advanced patient age. As you read through some of the older literature in like the 50s, 60s, 70s, 80s, would recommend that patients when they were older shouldn't even have, surgery as an option. And as we went through this study, what we really found is that patients could do very well that were older if they were, robust and did not have, frailty, a higher frailty score. And so this is kind of a helpful guideline for us. And it's not just been in vestibular schwannoma surgery, but this was the first kind of time we really showed that. This orange rock curve showing, frailty predicting outcome versus the blue in the middle, which is just, patient age. So as I'm going to skip this patient example of a case. We did translab resection, just get to the conclusions here as we're out of time. But, vestibular schwannoma management is complex, but it's incredibly rewarding. And I think it's increasingly important as you have older, more and more patients that are discovered to have lesions, these vestibular schwannoma tumors, and, what to do. The surgery is risky for facial nerve and for hearing preservation. One of the things I really like about it as a neurosurgeon is that there's really an art of medicine that's crucial to managing vestibular schwannomas. As we saw tonight, there's tons of, areas of important clinical questions where there's not a consensus or not enough evidence to provide strong recommendations. And so you really need to know your patients. Some patients are super anxious about having anything up there and they just want it out. Other patients, if you tell them it's okay, are going to be okay and you'll follow it with them, they're not worried about it. You also need to know your surgical limitations. It's great that there's a consensus statement written by all these amazing skull-based surgeons, but that could maybe translate very little into what is going on with your hands, with your patients. And so you have to know your patients, you have to know yourself, and be able to make, appropriate recommendations based on that. And, larger tumor size leads to worse outcomes. If there's one thing to remember, tonight it's obvious, but that's something to take away as a student is the higher the tumors are across the board, the worse, outcomes are. Cystic tumors tend to be much more challenging. Also, the planes between the facial nerve and the tumor can be really difficult to find. And post-radiation can also lead to, worse outcomes after if you have to operate. And so I'm a firm believer that in certain situations, subtotal resection and radiation is better than, being overly aggressive and getting a facial nerve paralysis. And it obviously depends on context and patient age and, frailty status and other things. But, I think this is kind of one of the, pinnacles of neuro-oncology and skull-based surgery are these tumors, because there's so many outcomes. It's not just about whether you get the tumor out or not, and maybe just like motor or speech, but it has to do with balance and facial nerve function and hearing. And, there's all these different treatment modalities of radiation versus surgery and which approach. And so, you as students, I'm excited that you're interested in this field right now. And hopefully you're going to be the ones that, make a significant difference in the future, because there's all these different scenarios where the evidence isn't there. And, we need people to keep studying it and keep looking at it. And so I'm excited for all of you. A lot of people, speak, bad about neurosurgery or say, I wouldn't do this residency because it's so long and this and that. But, I've loved my residency fellowship as an attending. It's a dream come true doing this job. Every day you get to help people and in these amazing ways. And these people that come to you with these very challenging problems. And, I'm, proud that all of you are, interested in and are pursuing it. And I would say that, this has given me such happiness in my life. And I'm just really grateful I get to be a part of like this amazing field and get to help, try and further this ball down the field. So thanks for your time. I don't know if there's any questions or if we're out of time, but I'll stop there. And just, this is what we all do it for, is our families, and, want to be able to provide care for, all people. But hopefully when your family is in trouble, you have someone that, cares a great deal for them as well, and is there to provide highly skilled and specialized research-backed, guidance.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.